Good morning, everyone, and welcome to today's webinar. My name is Tina Glover, the LifeLabs Key Account Manager and Team Lead in BC. And today we have a special guest, Dr. Navdeep Tangri, the creator and founder of ClinRisk Test, speaking on a new AI tool to predict the risk of chronic kidney disease progression. Dr. Tangri is the Professor, Division of Nephrology, Department of Medicine and Community Health Sciences at the University of Manitoba, where he obtained his medical degree. He also serves as the Scientific Director of the Chronic Disease Innovation Center in Winnipeg. Dr. Tangri's research program is focused on the clinical management of patients with advanced chronic kidney disease. During today's webinar, should you have any questions, please enter them into the Q&A function at the bottom right-hand side of your screen. And during our remaining 5 minutes, we will try to address as many questions as time permits. If we do not get to your questions during that time, please know that we will follow up with each question after the webinar. You can download today's handouts at the top right-hand side of your screen. For attendees that stay on to the entire webinar, will have a chance to enter to win one of 4 $25 gift card prizes. At the end of the webinar, you will be redirected to a contest entry page. During the presentation, I will post 3 secret words in the chat. Those that enter the 3 secret words will be entered in to win one of 4 prizes. Without any further ado, I would like to introduce you to Dr. Navdeep Tangri.
Thank you so much, Tina. I'm really delighted to present to this audience. We have such a diverse group today, and I get to talk about a subject I'm really passionate about, which is kidney disease, but also primary prevention. And I think a lot of this webinar is going to be about the 90% of kidney disease that sits outside nephrology care. Many of you would have interfaced with my colleagues, nephrologists, kidney doctors across Canada, and found that most of them are only looking after the very, very sort of the top of the iceberg, only the visible part, the really advanced chronic kidney disease and patients on dialysis and transplant, when most of the damage is really occurring under the water and under the surface and gets detected late. So we're going to talk about some new tests that are being offered by LifeLabs that can help you be proactive and offer truly value-added care to patients with or at risk for chronic kidney disease. Here are my disclosures. So I'm passionate about this work because we've only moved the needle incrementally in kidney disease in the last 30 or 50 years almost. From 1970 to 2001, we only used creatinine, and a creatinine of 100 was good, 200 was bad, and 300 was worse. In 2001, eGFR, or estimated GFR kidney function, was introduced, but still there's a bucket. Greater than 60 is good, 30 to 60 is bad, and less than 30 is worse. What that means is that people have no chance of being recognized until the number is below 60, which means 40 to 50% of kidney function is lost. In 2012, we had an introduction of a concept called the heat map, which was eGFR and albuminuria, or proteinuria. But still, there's just colors. Green is good, yellow is bad, red is worse, and people are in big buckets. Whereas what I think where we should be with the launch of these tests is an individual risk prediction, using machine learning, using AI, and using all the lab data we have at our disposal to determine the absolute risk of progression for individuals with or at risk for CKD. So let's start with how care is delivered today in Canada. First, there's a lack of personalized treatment. High-risk patients are undertreated and crash into dialysis, and low-risk patients are perhaps overtreated and get unnecessary side effects. Physicians, care providers, naturopathic physicians have really no accurate tools at the earlier stages when prevention matters the most. So you really just get a one-size-fits-all care model. And kidney disease is not a disease in isolation. Kidney disease leads to heart disease, it leads to liver disease, it leads to more difficultly controlled diabetes, and all this burden is far upstream of dialysis. So all the action needs to happen far upstream from dialysis. And finally, in the last 10 years, there's been a number of landmark new articles and new therapies to slow kidney disease progression, to in fact stop it entirely, to help patients achieve remission. but they don't reach patients early on in the journey because of poor recognition. And it's my view that a risk-based approach, an approach that's forward-thinking, can help transform kidney disease care. So I want to start out by presenting a few slides from the Kidney Disease Improving Global Outcomes, or KDIGO guidelines. These are the global guidelines for managing people with kidney disease. I was a member of this guideline group, and there are no Canadian-specific guidelines, and Canadian kidney doctors and patients with kidney disease in Canada should be managed with these guidelines. So what's old, what's new? One thing that's old and still consistent is that we still manage and stage kidney disease according to eGFR and albuminuria. So step one is still eGFR, albuminuria, and cause, okay? So start out by measuring the eGFR, whether it be creatinine or cystatin, and we'll talk about that. Measure the albuminuria in everyone with diabetes, hypertension, or kidney disease, and then try to put them together to determine the prognosis. And here is one way to think about it, okay? eGFR goes down the rows here, and albuminuria goes on the columns here. And you can see in one corner, you're green, where there's a normal eGFR and no albuminuria. And the opposite corner is bright red, where there's a low eGFR and lots of albuminuria. The reason for making this heat map in kidney disease is to show that both eGFR and albuminuria are equally important, and both are associated with all-cause mortality, cardiovascular death, acute kidney injury, and kidney failure. So you cannot look after kidney disease, you cannot diagnose it, you cannot treat it without looking at both markers. The next thing we really want to highlight is that the definition of kidney disease is still the same. It's either eGFR or albuminuria. So either an eGFR less than 60 or albuminuria greater than 3 milligram per millimole in our units, or 30 milligram per gram in American units. One thing that's very clear in the kidney disease guidelines that does not get advertised enough in Canada is that the guidelines recommend to measure eGFR with creatinine and cystatin C, and then estimate the risk of progression. So those two steps are missing in care the most. We don't often do cystatin C to get the best measure of kidney function, and we don't often estimate the risk of progression using tests like ClinRisk. And truly, once you've done those two things, you can declare that CKD is either present or not present. And actually, for most people with kidney disease, if cystatin C was available, the guidelines actually recommend testing through cystatin C. So if you think about an approach, the initial test could be eGFR creatinine, but if there are any concerns about the validity of creatinine, you should really measure a cystatin C. So what could happen that could hinder the validity of creatinine? Well, there's a large list, okay? So it's people with amputations, people with spinal cord injury, people with neuromuscular disease, people with heart failure, people with liver disease. So that's a pretty wide group, but it's actually much wider. Anybody with either low or high protein intake in their diet, so someone who's exercising a lot, taking any sort of supplements, or someone who's kind of frail and doesn't have a lot of muscle mass, a cystatin C is much more accurate than creatinine in all of those varied groups. And I would go as far as saying that if you need the most accurate measurement of GFR for clinical decision making, such as diagnosis or staging or drug dosing, you probably should get a cystatin C. There is some guidance in the guideline, like in extreme scenarios, like for transplant determination, you could do a nuclear medicine eGFR. But really, I would say that for almost all decisions where you have any doubt about kidney function, a cystatin C should be the next test. So how often do we measure eGFR? First of all, we want to measure both eGFR and albuminuria at least annually. So once a year is recommended for people who are either normal or mildly abnormal, and it's 2 to 3 to 4 times a year if you're more abnormal. And one interesting point we want to make is that an eGFR drop of around 20% in a person who gets retested is within the realm of normal. So we do not need to react and stop therapies or react and immediately start new therapies if the drop is less than 20%, because eGFR has a lot of variability. And again, creatinine and cystatin C together has less variability than creatinine alone. Many of you would have seen variability and change in the same patient with eGFR creatinine again and again. This is reduced with adding cystatin C. Albuminuria also has variability, particularly in small ranges. So if someone's albuminuria is 5, it could be 10 the next time, it could be 2 the next time. However, if it's greater than 20 or greater than 30, it's almost certain that it'll stay abnormal. So why are we talking about all of this? Why do we want to be really precise about measuring kidney function? Why do we want to be really precise about confirming the diagnosis? It's because we have a lot of treatments. Kidney disease now has both direct and indirect treatments. Now we know that kidney disease is often due to diabetes or high blood pressure. So we have treatments for diabetes, we have treatments for hypertension, we should consider statins or other ways to reduce cardiovascular risk or natural ways or diet. But we also have therapies now that can actually slow eGFR decline and reduce albuminuria. So it's really an amazing time to be in nephrology or treating patients with kidney disease, because you can do multiple things to stop their disease, to bring them to remission, which should be the goal. The goal in kidney disease should be to completely have a normal eGFR and no albuminuria. So how do we do this? I knew my audience today, so I wanted to spend a lot of time on things in the guidelines that we really focused on. So the guidelines completely agree that a healthy diet, physical activity, stopping tobacco, and weight management is first line before we even get into first-line drug therapy. In kidney disease now, there's a substantial amount of evidence that plant-based proteins or plant-based foods might be better than animal-based foods, and that the less processed, and particularly avoiding ultra-processed foods, has the potential to benefit complications such as acidosis, hyperkalemia, and hyperphosphatemia. So we recommend for our patients a plant-forward, minimally processed diet for kidney disease. The next thing I want to tackle is protein intake. So we would suggest maintaining a protein intake of at least 0.8 and probably no more than 1.3 grams per kilograms. We do not recommend low or very low protein diets for people with kidney disease. So somewhere between 0.8 to 1.3 is the sweet spot. Probably if you go higher than 1.3, you're risking some hyperfiltration and kind of wearing out the kidney. And I think below 0.8, you're risking sort of malnutrition possibly and loss of muscle mass. And we know muscle mass is really important for maintaining ability and preventing disability, preventing falls, and all of that. Okay, so that's a bit the protein piece, the diet piece, the plant-based diet piece, and really happy to take questions on that as we progress as well. Blood pressure control. So we recommend actually getting to a blood pressure less than 120 with a standardized office BP. So what's a standardized office BP? That means the patient is sitting in their room, in your room, for at least a few minutes, no caffeine, they've not just come rushing in, that you've taken 5 measurements, discarded the top, discarded the bottom, and averaged the middle 3. And with that, if we can get to less than 120, that's good for kidneys. And also we want to individualize, and in people who are falling, who are postural, we don't want to target 120, we can target higher. But I don't think most of those people are in our practice. I think for most people, 120 is achievable and something worth striving for. I want to talk a little bit about acidosis and potassium. These are common things in people with kidney disease. People with kidney disease, one of the things my patients always ask is when they look up kidney disease online, they are taught to limit their potassium. We really want to emphasize that that's only relevant for people who have a potassium of 5 or greater. If it's less than 5, the benefits of a high fruit and vegetable, a high potassium diet is actually is actually better or larger than the harms of hyperkalemia. Hyperkalemia is very manageable, at least up to 5.5, if not even higher, if not even 5.6, 5.7. So we do not discourage people to eat fruits and vegetables. We look at their serum potassium values, and if they're 5 or less, I do not restrict them, and I do not want them to be restricted. And I think this is a real thing that happens in primary care where people are limiting their fruits and vegetables as soon as they hear about their kidneys. So we don't want to do that. Similarly, metabolic acidosis. We know that people with low serum bicarbonate values tend to progress in their kidney disease faster, but we don't think sodium bicarbonate or baking soda is what they should be treated with. We want them treated with fruits and vegetables, with acid-reducing, base-producing fruits and vegetables. Now, these can include things like tomatoes. They can include, there's a list and just for all of your knowledge, I've been working with the Life Labs team and naturopathic physicians to develop a resource on diet, natural therapies, as well as pharmaceutical therapies for people with kidney disease. We've provided some notes on acid-reducing foods in there. We want these used first ahead of sodium bicarbonate. And that's not just my view, that's in the guidelines. So now let's get to pharmacotherapy. Pharmacotherapy for kidney disease is built now on a pillar of these 2 drugs, RAS inhibitors and SGLT2 inhibitors. So for most of my patients, they need to be on both of these treatments. So RAS inhibitors are ACE inhibitors or ARBs. We want them to use the highest and approved dose, and we don't want to stop unless the creatinine rises by 30%. SGLT2 inhibitors, which many of you are familiar with, empagliflozin, dapagliflozin. Again, we want everybody with diabetes or non-diabetes, as long as they have kidney disease or albuminuria, we want them on both RAS and SGLT2, and we want them treated because these drugs dramatically slow the progression of kidney disease. So that's foundational drug therapy. And the reason for this is there were 3 mega trials for SGLT2 inhibitors, Credence, DAPA-CKD, EMPA-KIDNEY. In all of these trials, and in the last 2, it was patients with or without diabetes, there was a 30 to 40% reduction in progression of kidney disease. So these drugs really help you, the foundation, by stopping kidney disease in its tracks, effectively slowing the progression down to almost undetectable. Now, some patients need even more therapy, and thankfully, we have even more options. So in addition to RAS and SGLT2, for people with diabetes and kidney disease, so think about all your clients who have diabetes and kidney disease, they also benefit from non-steroidal MRAs, a drug called finerenone, and GLP-1s, which you're very familiar with, Ozempic or Mounjaro, on top of RAS and SGLT2. So if you think about pillars, the bottom pillar is a plant-forward diet, healthy lifestyle, leveraging fruits and vegetables, not restricting unnecessarily, improving physical activity. Next pillar, RAS and SGLT2. Next pillar, non-steroidal MRA or GLP-1. So in diabetic kidney disease, we actually have 4 potential agents. In non-diabetic kidney disease, we just have RAS and SGLT2. So how do you prioritize? Who gets just the lifestyle pillar? Who gets just the first 2 drugs? And who gets all 4? Well, the way to do it is to use risk stratification. Remember, cystatin C is about knowing where the person is today. It's the best test of what the kidney function is today. But we not only need to know where the kidney function is today, we need to know what the kidney function is going to be in the next 5 years. That information about the future, the prognosis, is what determines how we treat our patients and with how much intensity. So what we've done is we've developed models and validated risk equations that predict the risk of progression of kidney disease in these people, in everybody with or at risk for kidney disease. So I'm going to show you some downstream equations, and then I'm going to show you our upstream equations, because I senses that you do a lot of upstream work. So first, the downstream. So these are equations we developed. I developed these. They're on kidneyfailurerisk.com. This is for later stages, people with CKD 3 to 5 looking at their risk of dialysis. They are available through LifeLabs also. There's a simple lab-based equation. It has age, sex, GFR, ACR. It's called the KFRE, or the kidney failure risk equation. Many of you in Ontario may have seen this on lab reports. It's in more than 50 countries, 4 million individuals. It's part of every guideline. It's used by 200,000 physicians worldwide. So this helps you determine the need for dialysis in people who already have late-stage kidney disease. But the important thing and the subject of this presentation today is early intervention. We want to act early. So when you look at a patient who is high risk, that patient typically starts treatment and is recognized when their kidney function is 40%, okay? Whereas they should be recognized when their kidney function is 80%. And if we did all the right things at 80%, we would delay dialysis by 29 years, and we would reduce heart failure hospitalizations by 65%. And that's if they're high risk, okay? So you could avoid dialysis, avoid transplant, halt CKD progression, reduce CV risk. Now, even if they're moderate risk or intermediate risk, and you put them on 3 drugs and you intervene early, you can actually then prevent lifetime risk of dialysis. So you have this opportunity because you're seeing these patients when their GFR is 80. The nephrologist is only seeing them typically when the GFR is 40 or lower. That you get them on the right treatments, you can prevent lifetime risk of dialysis and reduce heart failure by 65%. So that's the promise of early intervention in kidney disease. Now, here is the problem. There's a challenge to deliver early intervention. There are 3 gaps that make the patient fall into the water and not let early intervention happen. So the first gap is that the right tests don't get ordered, okay? So what happens is we have a focus on serum creatinine or eGFR, and we don't order albuminuria or urine ACR. So what happens as a result is we miss all early disease because eGFR is greater than 60, so we can't even detect early disease. The second is that the tests need to be interpreted appropriately. For the majority of patients in Canada, if their eGFR is above 45, even if the albuminuria is abnormal, people ignore them. They think their disease is early, it doesn't need much attention, they just ignore it. And finally, the right therapies need to be started. So even if the physician recognizes that albuminuria is a problem and they want to do something about it, if they just stop at the first pillar, which is RAS inhibitors, the patient misses all the benefits from multiple treatments. And the treatments all stack on top of each other. So delivering a holistic intervention in early stage gives you the maximum benefit. So the reason I'm here today is because we've developed a test called a ClinRisk test, which solves all 3 key gaps in care. There's a panel, the test creates a panel that includes eGFR, albuminuria, chemistry, and CBC. So you do the whole comprehensive set of kidney testing, nothing gets missed. We provide interpretation. We tell you whether the patient is low, intermediate, and high risk. In the materials, you can see sample reports. And then finally, we link the risk to treatment. We provide recommendations and personalized decision support, in addition to the user guide, which we will provide as well. Let me give you some background so that you can have the confidence that this test was built in the right way. So the problem we wanted to solve was for all stages of kidney disease, focusing on early stage and people with diabetes and hypertension who don't have kidney disease today. That's who this test is for. People with early stage, or people with diabetes, or people with high blood pressure, not and, or. And the test predicts the risk of losing 40% of your kidney function in the next 5 years. And that's a really powerful endpoint. That means that if you're at 90 today, you would go to 54 in 5 years, which is a very, very large loss in eGFR. It's also the FDA Health Canada approved endpoint. And this test uses just a CBC chemistry panel ACR, so it's just routinely collected lab data. It's really a model for everyone. You could be confident that we built this test in Canada. We started out in 77,000 people in Manitoba, where we got the initial data. Then we validated in 100,000 people in Alberta. Then we validated in large clinical trial data sets, which had populations from all over the world. And recently, we validated in 5.7 million Americans. In total, we've now validated and proven that this test is accurate in almost 6 million people. That's more than any other test in kidney disease, and probably in a lot of other areas of medicine. First, this test is more accurate than what you're using today, which might be eGFR and albuminuria, and certainly more accurate than just eGFR alone. Here in the Canvas and Credence trial, we showed that our test was 81 to 88% accurate, whereas eGFR and albuminuria were only 74 to 83% accurate. Importantly, there was 30-fold separation in high and low risk groups. So patients who we label as high risk have a 30 times higher risk of progression than low risk. So we really need to pay attention to those high risk patients. And when you treat them, the risk goes down. So you can retest patients after you've done a number of treatments, and within 6 months, you'll see a separation in risk. So what does this mean for the patient in front of you? Let's look at the example of SGLT2 inhibitors. So this is empagliflozin, dapagliflozin, great drugs for kidney disease. When you look at people, 1,000 people treated for 1 year, you prevent 11 kidney disease progression, 11 cardiovascular death, 4 acute kidney injury in people with diabetes when you treat them with an SGLT2 inhibitor. Seems really good, right? What this means is that you have to treat 32 to 46 people to prevent 1 serious event. And that's a pretty good return in medicine. Treating 40 people to prevent 1 event is very good. What we showed is that when you run our test and somebody is high risk, you only need to treat 5 high risk people to prevent 1 event. So your return on prescribing is like 8 to 1, right? Compared to treating 40 people to prevent 1 event, you only need to treat 5 high risk people to prevent 1 event. And that's shown nicely here. High risk people have a slope of eGFR, or a rate of decline of kidney function, of -6 every year. And with SGLT2 inhibitor, it drops to -2.8. So that means they have a total benefit of 3% per year every year they're on therapy. Intermediate risk people have a total benefit of 2, and low risk people have a total benefit of 1. And that's true not just of SGLT2s, it's true of every single drug that you may be considering. High risk people have the biggest benefit. So when a patient is on the fence, I can show them a high risk report, and I can assure them that they, of everybody, really need to consider this therapy because they are truly the highest risk. The other thing we show is that high risk, even though the test only predicts out to 5 years, that high risk people continue to do worse even 15 years out. So in this study in 1.1 million people, we showed that even 15 years out, high risk people were doing poorly compared to lower risk people. And in fact, 10 times as worse, right? Remember I said 30 times in 5 years? Even at 15 years, high risk people do 10-fold worse than low risk people. So when you order our test and you see an abnormal report, a medium or a high risk report, that's a patient that's ignored by nephrology and ignored in primary care in a lot of settings, but that deserves treatment. Now, how is the treatment of these people today? Well, this is data from almost 1 million people showing that high-risk people don't get any better treatment at baseline at today's practice given compared to low-risk people. So you may ask why that is. And I would say the reason that occurs is because high-risk people's creatinine or eGFR is volatile. Like it goes up, it goes down, visit to visit, because they're high risk. And because of that, people stop therapies. They stop their RAS inhibitor. They stop their SGLT2 inhibitor. They stop their GLP-1 because they see the bumps in creatinine. Now, if you knew the person was high risk, you would be much more likely to persist. And that's the power of visualizing risk and knowing what's going to happen to someone in the future. You're much more likely to stay the course with a person like that. In another study of 4.6 million people, we showed that high risk is not just high risk for kidney. It also leads to 3 to 5 times more healthcare costs and 5 to 10 times more inpatient visits and ER visits. Now that's really important, right? Because we have a constrained system, especially in Canada. We have ER wait times. We have hospitals that are totally full. We don't want patients to end up there. And again, treatment of high-risk patients is most likely to result in prevention of inpatient visits and ER visits. On this slide, what we wanted to show was that high-risk patients and low-risk patients are not that different in their historical utilization. So they're 13 and 10 or 16 and 12 in historical hospital utilization. But moving forward, they become 14 and 4 or 25 and 7. The point I'm trying to make is that the test tells you something about the future, something more than you know from historical utilization. So ignore the past trends a little bit and focus on the blood tests today. The blood tests have a lot of information. So what's driving all of this in our patients? In people with or at risk for kidney disease, what drives risk is chronic kidney disease and heart failure. Okay, these are 1 and 2. They're ahead of stroke, MI, or peripheral arterial disease in all of these patients, whether it comes to hospitalizations or it comes to costs. So when you see people with kidney problems, think about all the interventions that we discussed and recognize that those interventions and every other action you take will prevent both kidney disease and heart failure. When somebody has kidney disease, they need help for kidneys and heart. And actually, when somebody has heart disease, they need help for heart and kidneys. This is why some of you may have heard a term called CKM or cardio-kidney metabolic syndrome. We are now thinking of kidney disease, heart failure, and diabetes together. And consider testing people with heart failure or diabetes for kidney disease, and consider testing kidney disease patients for heart failure and diabetes. Ultimately, what we want to do is move to an era where you can deliver personalized medicine. I think of 100 people with kidney disease, and I think that 50 of them are green. They just need lifestyle management, improvement in how they eat, how they live, and perhaps RAS and SGLT2 inhibitors, which is foundational therapy. But there is another 50% out there that's yellow, orange, or red. And those people need early and aggressive care, including 3 or 4 medications. And if we recognize them early, as I showed in my example, you can delay dialysis by 3 decades or prevent it entirely. Whereas if you wait till nephrology, it's just too late. So the last kind of 35 minutes, I've given you a lot of information about how to diagnose kidney disease best and how to see what's going to happen to the trajectory of the patient. But now let's go into how it actually works. So our test, the ClinRisk test, works with Life Labs and utilizes only a CBC, a CMP, a comprehensive metabolic panel, and urine ACR. So here's how you operationalize. You order the ClinRisk test using the requisition that's in the tab. The patient goes to Life Labs and has the blood and urine test done. Life Labs sends us the results via a secure API, and we return to Life Labs and to you a personalized risk assessment and a guideline-directed care plan. What we do is simulate a virtual nephrology consult. We give you 80 to 90% of the knowledge that a nephrologist would give you for this patient. And what we try to do is connect these dots. So first, on the one corner, we tell you what the patient's risk is. So this is 60% high risk, 60 out of 100 stick figures are red. This patient really needs everything done. And then the report tells you every single thing you need to know on what to do with the patient, how often to monitor, the management of comorbidities, when to refer to nephrology, what should be the blood pressure target, what other complications of kidney disease are present, and what therapies can be helpful to slow CKD progression. Again, we are trying to enable early and upstream nephrology level care for the bottom of the iceberg, for all those patients with diabetes, hypertension, and who are at risk for chronic kidney disease. This type of care is just not available to most Canadians in today's healthcare system. The other thing we've shown is that alerting providers to this actually improves quality of care. So we did a study in 20,000 people in Texas where we ran these reports and we showed physicians patients who were high risk. What it turns out was that those patients were 90% more likely to achieve appropriate testing, 40% more likely to achieve RASi use, 200% more likely to achieve SGLT2 use, and 80% increase in MRA use. So what happens is that all of us, you in the audience, my colleagues in primary medicine and nephrology, all of us want to do the right thing. But when we don't see risk on our own, when it's made visible to us, we act, we do the right thing. Making risk visible matters. And that's what this test is all about, is to identify patients at elevated risk of disease progression earlier so healthcare professionals can prevent decline. And that's kind of the central message, right? Is we can show you risk much, much earlier in the journey, and then you can act and make sure that patient actually forget needing dialysis. That patient never even needs a nephrologist. The other thing I want to highlight is that if patients have a healthcare spending account or a flexible spending account or a deductible allowance, most of the time, this is reimbursable for the use of this test. So if patients have those allowances and if they have amounts remaining for the year, this test can be used and that cost can be leveraged. Another important thing that I think is worth mentioning is that shared decision-making is essential so that patients work on their treatment plan. And shared decision-making allows a medication review, it allows patient-centered management, it requires an ongoing management, and a discontinuing and restarting medications strategy. When you take this report, and such a patient-friendly report, you take this report, you share it with your patients, they see it in their MyCare compass. You can have a much more robust discussion about what to start, what to stop, and why it's needed. And that helps us not just start the medication today, but it also ensures that the patient will likely stay on therapy, whether it's a diet, an herbal, or a pharmaceutical drug for the long term, because we know patients stop medications over time. But a patient who knows their risk, who knows the reasons for starting the medication, is less likely to stop. We're going to have lots of time for questions because this is my last slide. The best time to intervene in kidney disease is before the nephrologist. Let's face it, we're in Canada, whether you're in Ontario or BC or Saskatchewan, nephrologists are seeing patients when kidney function is usually between 30 to 45. We need to act much, much earlier, before half of kidney function is lost. Staging is only the beginning. And cystatin C can help you achieve better staging, better diagnosis, and it can really clarify what the kidney function is today. But that's one piece. Risk stratification must follow. And the risk of progression can now be calculated using the ClinRisk test, and it's available at LifeLabs. What we need to do is match risk to treatment, okay? So high-risk patients, high-intensity therapy. Low-risk patients, reassurance, low-intensity therapy. They don't need the side effects. They don't need the cost. And that's what sharing of information does. This test enables sharing prognostic information that removes clinical inertia, which is the biggest barrier in evidence-based prescribing. And it engages the patient to participate in their care plan. And that's really what this is all about. It's like none of this matters. All the science in the world doesn't matter if the patient doesn't follow their care plan. And I think a lot of what we've done, certainly a bit of what we've done, is to help you engage your patient and help us all be all on the same team. So with that, I'll stop and really happy to take questions.
I want to say thank you, Dr. Tangri. That was a wonderful presentation. There's a couple of things, though, I just want to make sure we understand here is that, there's going to be two reports that the practitioner will receive. The first one that they will receive is their LifeLab 16 component test, which is their conventional core testing. That will come first. And following that will be the ClinRisk report. And the ClinRisk report is a non-fasting test. So I just want to make sure that the patient is understanding, or your patient's understand they need to be non-fasting going in, and a specialized requisition required. And then I'm just going to go straight to the question that was above here. In today's presentation for you, Dr. Melissa Johnson, just today's presentation was to introduce this test and to introduce it as a whole with the algorithm and the report that you receive with the high and the low, which is pharmaceutical presentation on that sample report. Why we added the therapeutic component and didn't go into it as a big dive today is really, we just recently had Dr. Tangri look over all of the aspects first to get his approval on it. And we will be handing out that material a little bit later. So it's not that he didn't want to focus on it, it's that he wanted to present this test and the information of this test. I hope I've answered your question well.
Yeah, and thank you, Tina. And I can just respond to Dr. Johnson as well. So I think part of it is that I think you should hear from the experts in botanical medicine from the on this, not from me. And we plan to have webinars on ClinRisk with your colleagues who have more expertise in botanical medicine. I have no doubt that a holistic approach is best, but I just didn't want to step outside my expertise, and I wanted to kind of leave that for a second webinar on this topic.
Absolutely. Thank you so much, Dr. Tangri. We have another question here. The reduction of progression of CKD based on pharmacological therapeutics, how is that calculated? Are they predicted risks plus clinical outcomes? Have other therapeutics been studied in as much detail as pharmaceuticals have been able to provide?
Yeah, so this is an excellent question as well. So the way we calculate the risk and slowing is we take the person's predicted risk. So let's take an example with round numbers. Let's say it's 20%. And we assume, which is a fair assumption, we've tested this in our studies, that SGLT2 inhibitors will slow that down by 0.7 or a 30% reduction. So we take 20, we multiply by 0.7. So we say it's 20% without SGLT2 and it's 14% with SGLT2. So that's how we calculate it. There's I'm going to just put in the chat here. There is a website we've developed that shows all of these calculations and the effect, and you can feel free to browse and give us feedback. It's actearlyonkidney.com, and please feel free to have a look. I think that might help some of your questions. We provided all the details on the calculations there as well. Again, I think we are planning to certainly have a session and a webinar on sort of non-pharmaceutical therapeutics. I could tell you fruits and vegetables for metabolic acidosis in kidney disease have been studied in as much or if not more detail than sodium bicarbonate or pharmaceuticals. So I stopped and specifically mentioned that. I wanted to also address the potassium and diet myth, because we really firmly believe that especially people with a normal potassium should not restrict. And the number one things people do is restrict their potassium. So those are two areas, potassium for hypertension, fruits and vegetables. that have a lot of study, and I'll let my ND colleagues kind of dig more into the evidence on the other topics.
Thank you, Dr. Tangri. That was well said. We have another question here. Does ClinRisk take ethnicity into account in its ranges interpretation?
Yeah, so we do not take ethnicity into account. Ethnicity is like a complex social construct in a way, race/ethnicity, and there's a lot of people who are mixed ethnicity, which make it challenging to label. So what we did do is in our studies in the US, we had patients who were Black, sort of non-Hispanic white and Hispanics, and we had people of low, medium, and high socioeconomic status, which we could determine in the US based on their medical insurance. And we were able to show that the model is equally accurate in people across those ethnicities and those socioeconomic status variable. And I just think of it as a mixture of all of those things. And I think you can feel reassured, given the volume of people we've used it in, that it's definitely the case, that it's valid.
Great, thank you so much. We have another one. The 1.1 million people, what sort of study was that? Looking at data over what years, just in Canada?
Yeah, so it was the Canadian data so far is in 180,000 people in Manitoba and Alberta. The 1.1 million people was in the US. It was over 15 years, and it was a lab data repository from Optum United, which is the largest health insurer in the US. So we were able to work with them and get access to that data over 15 years.
Great, thank you so much. Here's another question for you. NDs have always offered personalized medicine. It's what we do. And I want to acknowledge that you do a fabulous job on this. NDs do. Again, I want to reiterate today's presentation was to launch this test and to really explain the reporting that you will get, which is on the chat attachments, handouts with the highs and lows. We have another question here. If cystatin C is superior to creatinine overall, why was it not used in the ClinRisk assessment?
Yeah.
Really good question.
So it's a really good question. So first, I think that the data we use to train the model, which is the 77,000 people, they did not have routinely collected cystatin C. So let me sort of explain this in sort of modeling terms. So currently what's happening in Canada and in many parts of the world is a cystatin C is only being done in people where somebody is worried about the accuracy of the creatinine result. So the people who have a cystatin C in the system tend to be very different than the general population. So if we build a model in them, it won't be accurate in everybody. Now, the ClinRisk model requires eGFR. It doesn't take creatinine, it just takes eGFR. Now, if I had a cystatin C and a creatinine or a combined eGFR, that's fully valid to use that in the model, and we have used that. So I think as cystatin C use goes up in the more general unselected pool of people, we are very happy to accommodate it. And I think there's no doubt in my mind that it's the best test for kidney function.
Thank you for that. Another question, are there any medications that are contraindicated?
Yeah, so I think in terms of things that are contraindicated, in kidney disease, really it's, we don't put this in the resource, but it's an excellent point, would be baclofen, gabapentin in very high doses, prolonged daily NSAIDs, but we should put this in the guidance, and metformin below GFR 30. I think there's like, I just didn't think of that, and that's a great point, and we can update the guidance because it's still not published yet.
Oh, good, really good question. Thank you for that feedback. Question again. I agree about hearing from experts. I just like to hear it mentioned. Thanks for your response. So that's on the therapeutic, yeah. And I see that you've put in there, Dr. Tangri, the information on the information website. We have, does this tool include guidance on medication dose adjustments or discontinuation if indicated by the test results?
Yeah, so this is an excellent question. So we've I think we flagged potassium, and we don't recommend, for example, if the potassium is high, We don't recommend, initiation of RAS inhibitors or MRA. So there's some feedback in there. The great question that just came up about discontinuation regarding metformin or other things, I think we're going to put that in the user guide. So that's a really useful thing. So that's a great point. So we'll try to make that point. Otherwise, we should add more of that. So I just take that as good points and we'll add them.
Yeah, thank you for that. These are really good questions, guys. Keep them coming. We have another question here. Thanks so much for this information. It was very informative, so I wanted to share that. That's what's in the chat. Another question for EGFR: how many times would it have to be run to establish a pattern of our out of normal ranges before the ClinRisk becomes actionable?
So I think the test is both EGFR and albuminuria. So always considering both of them. I would say any 2 abnormal measurements is abnormal. So you don't need to run it a bunch of times. And in fact, you don't even need to run it. You don't even need to run it on your own if you see 2 previous measurements that are abnormal. And ClinRisk is actionable as a way of screening for kidney disease also, even in people that have normal readings but have diabetes or hypertension. Then it kind of works as a screening and a prognostic test. So you could use it in that way. But again, any 2 historical abnormal measurements of EGFR or albuminuria, that's abnormal. Don't need a whole bunch more. Great question, great answer. Thank you so much. Another one here. As creatinine is a very commonly used supplement and has been reported to increase serum creatinine levels clinically, what is a reasonable percentage range increase in creatinine that could be expected prior to testing cystatin C? So Jeff, this is a really terrific question, and one that I actually get a lot of consults for. So I sometimes get young people who are supplementing and there's a question about kidney disease. In my sense, it's not easy to figure out because we don't really have part of it is their diet, but part of it is also like how much muscle mass they have on, right? So I think if the patient is willing and you're willing, if the patient is supplementing, that's like a perfect use case for cystatin. So it would be very hard for me to give you a number on like a percentage on this. I would think the much easier way would be just to get a cystatin on those people.
Great question. Next question is it a good idea to do these tests on all patients as a baseline or only GFR creatinine only?
Great. So let's think about this in 2 ways, right? Like we have to think about a patient-centered way and kind of a provider care pathway, right? So if you asked me, if I was a patient and I said, I want the best tests that I can get, right? I think there's no doubt, like you should probably do a cystatin C and a ClinRisk, and you would have an idea of what the patient's kidney function is and what they need to do. If a patient said, I want to follow a sequence where I want to do a set of tests first, and then a second set of tests, and then a third set of tests, right? I think you have to do urine albumin and creatinine at least on everyone. And I think that if they don't have any protein supplementation, any low or high muscle mass, or any of those other things, maybe that creatinine is reasonable enough. But there's a big list of things where creatinine is not that reasonable, right? And I think if the urine albumin or the creatinine is abnormal, then there's a very compelling case to do a ClinRisk test and see how serious this disease actually is. So it just depends how willing the patient is in front of you, and how much they like. Do they want to be very comprehensive right from the beginning, or do they want you to start narrower and then go broader? So I think that's how I would think about it.
Great question. But I have a follow-up just on this. Is how often do you think they should be running this test? Can you give some examples of that?
So I think annually is a very reasonable framework, particularly for people that have an abnormal test, right? Mm-hmm. So I think annually is quite reasonable. Now, in some people, the people who are changing very fast their clinical status, you may need like twice a year, 3 times a year. But that's, those are not going to be that many people. If you're changing that fast, you may as well, you probably need a nephrologist working with you alongside your ND. So I think annually is a very good framework for most people.
And from a monitoring point of view, if they are borderline high, how often should they be, be reassessed here for the blood work?
Again, I think if they're borderline, annually again sort of works, unless something clearly changes, right? Like unless somebody says, I've now made a bunch of diet and lifestyle changes and I'm taking this other therapeutic. And then you want to see the effect of that. So there's a bit of cause or effect. Yeah.
Perfect. See, we have another question here.
Yeah.
How high is the protein intake a flag for running this test? Many are on protein smoothies. What about patients, that are about taking creatinine supplements as well?
I think if any of those patients come to you and they are concerned about their kidneys, it's a perfect use case for running the test. I basically, I would say that anyone above 1.3 gram per kilogram, right, is probably, that's a lot of protein, enough to affect their creatinine for sure.
Right. Great question. And there's something else I wanted to add that I don't think we've mentioned here, Dr. Tangri, about this test, which makes it very unique, is the patient not only needs to be non-fasting, they need to be coming to the lab doing both a urine test and a serum test. So I think we do need to make that known. I think the other thing I want to make them known is if they're mensing, they can still run this test as well. Yeah. And they must be 18 years plus, correct?
Yes, they have to be 18 years plus. Yeah.
Okay, great. I'm just wanted to give a moment just to see if any of the other questions are in our chat and moving them over into our,
So I think, from my perspective, I'll add to the audience that as you go out and you order the test and you receive reports, we are very welcome, and I'm very open to feedback, right? We'd love to receive your feedback on what you found helpful, what you found didn't helpful, how we could make it better. Because I think that we don't, myself as the developer of the test, and LifeLabs teams, we don't plan to have all the answers on day one. So please, so I think the test is very accurate in people 12 to 18. We've done a study, we've proven it, but just with Health Canada and so on and so forth, we've just not made it available for people under 18. But it is very accurate at 12 to 18. I can assure you that. Under 12, I have no data, but 12 to 18, very accurate.
Okay, that's good. Good question there too. Where is the pricing for the ClinRisk test on LifeLabs? Can NDs order this test? Dr. Julie Chan, I think you might be in Ontario. I'm not sure, but yes, it's a new test. We've just launched it actually within this last week, so hence why we're doing this webinar now. It is $86. It will have a doc fee. So if you have a patient that has a requisition for other tests, and your patient has 2 requisition forms, you will only be charged with the one doc fee. So I just want to answer that question too. That would probably be a question that was out there. And I have another question here. Is this test run on elderly where they do have declining GFRs? Would the interpretation keep in those cases?
Essentially, you summarized like one of the perfect use cases. Basically, this will help you determine whether that person's like declining GFR is related to aging, or is it actually something to worry about? So if that person and if that older adult becomes low risk, you can really reassure them. And if that older adult is medium or high risk, you really need to be aggressive to treat them. So, and half are going to be one way and half are going to be another way. And that's where this test is really, really helpful.
Yeah, absolutely. Was there any other questions that people may have? We have 1 minute left. And so I have just another question. If somebody is, 55 above, and I know you talked a lot about certain patient types with disease, but what about some patients that are starting to take a lot of, pills as they age, as they get elderly, they're taking a lot of different prescriptions. Would they be candidates as well?
Yeah, absolutely. I think that there's some of those medications, and I think there's a great point here about medication discontinuation and roles. I think some of those medications would be, I just sense that, the indication population is diabetes or hypertension or kidney disease, right? And I see so much, it ends up really covering about 1 in 3 to 1 in 2 older adults.
Right.
That's not to say that it's not accurate in people who don't have those things, but in those 1 in 3, 1 in 2, it can really, really be useful, and it can help them prioritize. So I'll give you an example. So if somebody just has high blood pressure, right, they can be on one of 6 therapies, pharmaceutical therapies. Again, sorry, I'm only speaking about the drug therapies for this question. They could be on one of 6 drugs for high blood pressure. But if their clinical score is moderate, maybe they should be on an ACE inhibitor or ARB instead of any of the other ones. Same thing with diabetes. If they're on metformin and they're doing okay, but their test is moderate, even though they don't have kidney disease today, maybe their next drug should be SGLT2 and not a DPP4 and not a glycoside and not anything else. So it can really help you personalize that next step in care.
Yeah.
So think about it for people with kidney disease, of course, or people who have kidney concerns, but also about people with diabetes or hypertension to guide what's the next thing they should be on. Yeah.
Great answer, and a great way to say how to optimize the medications that they're on is really what I'm hearing here. In the interest of time, I just want to answer one more question on the recording. Yes, I want to answer this has been recorded. This will take about 10 days to 2 weeks to upload because we edit and go from there. But in the interest of things like that, and time on those things as we edit, I want to say thank you so much, Dr. Tangri. This was a wonderful, engaging conversation. And it's so fun to be a part of an AI to predict how we can optimize kidney care. And I thank you again. And we look forward to working with you in the future here.
Thank you. Thank you so much, everyone.
Bye for now.